נשאיר אותה.
בוקר טוב לכולם.
דבר למיקרופון בבקשה.
אפשר לקבל את זה, השקית הירוקה.
שומעים?
לקחתי לך את המקום?
לא, בסדר, שומעים.
בוקר טוב לכולם. שמי סילביה פסלזוביק ואני מנכ"ל קרן טאובר ויושבת ראש איספרה. תכף אני אגיד שני משפטים על זה כי מישהו שאל אותי ואני מעט אני כבר אסביר לכולם. אנחנו נמצאים היום באירוע קטן. אנחנו ביקשנו לקיים שולחן אינטימי לגבי נושא שמאוד מאוד מאוד חשוב אבל עדיין לא כל כך נדון בארץ, וזה עוני ובריאות נפש, נפש ועוני ומה הקשר ביניהם. אנחנו הבאנו לצורך זה מומחה מאנגליה, דוקטור ג'ד בורדמן, וזו הפעילות השלישית שאנחנו מקיימים איתו, והפעילות הראשונה הייתה איזשהו שולחן עגול קטן במשרד הבריאות, ואתמול אנחנו קיימנו כנס בשותפות עם אוניברסיטה העברית, והבנו מהתגובות שקיבלנו בכנס שעלינו פה על משהו, שזה באמת נושא חשוב, דחוף, דוחק, שלא מדברים עליו, וגם כותרת המשנה של הכנס הייתה למה לא מדברים על זה, ואנחנו החלטנו להתחיל לדבר על זה. אני מאוד מאוד מודה לג'וינט על השיתוף פעולה הזה, על העזרה המאוד מאוד גדולה בארגון היום הזה, הסמינר הזה, שולחן הגדול, איך שאנחנו רוצים לקרוא לזה, שהמטרה היום היא בעיקר ללמוד מה ידוע באנגליה עולם, מה ידוע בארץ, ומה צריך לעשות כדי להעלות את הנושא הזה על הסדר היום גם בישראל. אז אני מאוד מאוד מודה לכולכם שהסכמתם לבוא. היום מתחלק בגדול לשני חלקים. החלק הראשון, ג'ד יציג לנו את מה נעשה באנגליה, ואחר כך יש לנו מספר דוברים שידברו באמת כמה דקות מה בארץ, ואחר כך בחלק השני אנחנו נפתח את זה לדיון, כי באנו בעצם ללמוד גם מכם, וגם לא רק מה קיים, אלא מה לפי הניסיון שלכם, לפי התחום שלכם, מה אפשר לעשות כדי להתחיל פה איזשהו שיח. ואת החלק הראשון, כדי שכולם יודעים מי נמצא פה, אז אני אבקש שכל אחד יציג את עצמו במשפט אחד. אני רק אסיים כרגע להגיד מה זה קרן טאובר ומה זה איספרה. קרן טאובר זה קרן פילנתרופית, משפחתית אמריקאית קטנה, שפתחה את שעריה בארץ לפני 8.5 שנים, ועיקר פעילות שלנו זה תחום בריאות הנפש בכלל ושיקום פסיכיאטרי בקהילה בפרט. איספרה זה אחד הארגונים שקרן טאובר הקימה, וזה ארגון פלטפורמה בעצם לכל האנשים שעוסקים בתחום השיקום הפסיכיאטרי, ובכלל ארגון שבשאיפותיו לקדם את הנושא הזה יחד עם שותפים כל כך רבים בתחום גם בארץ. השיתוף פעולה היום זה במסגרת איספרה יחד עם הג'וינט, ושוב אנחנו מודים לג'וינט על האכסניה ועל הארגון. ובואו נתחיל מפה.
ברוך רוזן, אני מנהל את המרכז לחקר מדיניות במכון ברוקלין.
אפשר להביא את המיקרופון אחד-אחד? זה מספיק ארוך?
אני חושב שלא.
נראה לי שיצטרכו להגיד בכל רם.
אוקיי, תגידו בכל רם. אתה כותב כל אחד? או שאתה רוצה להגיד? אוקיי, יש פה בקשה. ג'ד ואני כבר מכירים, אבל אם האחרים יכולים להציג את עצמם באנגלית, בבקשה. מי שיכול, מי שלא נוח לא נוח.
I'm Bruce Rosen, I direct the Center for Health Policy Research here at the Brookfield Institute.
I'm Uri Aviram, a retiree from the Hebrew University of Jerusalem, and currently I'm with the European Academic College, and not too far from Hadera, if you know where it is. The rest would know.
אל תלחש. לא שמענו כלום.
ככה זהו כשהוא מדבר חזק.
יחיל ששבסקי, לשעבר ממונה שיקום במשרד הבריאות.
Max Lachman, I'm the consultant of the Tauber Foundation and also member of the ISPRA board.
Sharon Rothschild, the head of the vocational rehabilitation in the Minister of Fire.
Gabby Admonrick, and the Commission Paper Rights of People with Disabilities in the Ministry of Justice.
Shuli, Israel Unlimited.
Israel what?
Unlimited. מסד
משרד
נחויות.
נחויות.
עידית סרגוסטי from בזכות Human Rights Center for People with Disabilities, an NGO.
Chaim Fialkov, I'm a consultant to the Joint from Hebrew University.
רותם פיליפס ממשרד נחויות.
Suad, I am from the JDC. I work with Arab people with disability.
Daniel Gottlieb, head of the research and planning at the Social Insurance, and also professor at the School of Social Work at the Hebrew University.
Yona Rosenfeld, I'm now at the Brookdale Institute, where we have established a unit of learning from success and ongoing learning in human services. I'll leave it at that.
Denise Naon from Brookdale Institute.
Daphne Haran from Brookdale Institute. I work at the Center for Disabilities, and I focus my research on people with severe mental illness. I also making my PhD at the School for Social Work at the Hebrew University on this subject.
Vital Sandler-Leff, I'm the head of Israel Unlimited, which is a strategic partnership between JDC, the government of Israel, and the Ruderman Family Foundation to promote services for people with disabilities. Now I can breathe. And I also oversee the issue of disabilities in JDC worldwide.
Avi Oren, I'm from the Ministry of Economy. I'm in charge of the integration of people with disabilities in the public services. And the other head is I'm the coordinator of the policy of mental health in the consumer movement in Israel.
I'm Dori Rivkin, the director of the Center for Disabilities here at Brookdale Institute of Research.
Yael Ashkenazi, I'm a researcher at Brookdale Institute at the Smuggler Center for Health Policies.
Eli Shamir, retired mathematician of the Hebrew University and up to this year, chairperson of the NGO Otzma, families of persons with mental disabilities.
Avi Fleischman, I'm from JDC Tevet. We are working especially, my department is working on developing an employment program with the government for people with disabilities.
I'm Ayelet Raymond. I'm also from JDC Tevet. Also director of some of the employment programs, and some of them for low wage visa.
I'm Galia Moran. I'm from the social work department in Ben Gurion University. My research focuses on psychiatric rehabilitation and recovery, specifically peer providers, and also how to help providers become more person-oriented and development of interventions along the lines of just growth.
I'm Tami Matzlavi, head of Lishma, non-profit organization, consumer organization.
Kirk Ninimander, area head community services, Israel.
Daphne Levinson, research and development, research and planning, the Ministry of Health, mental health services.
Okay, תודה רבה. Thank you, Jet. Let's go to work.
Okay.
20 minutes, okay?
Yeah. Jet, there's no wires.
Oh, that one, does it? Oh, nice. That was for yours.
Thank you. Should I stand up? Actually, might be better. Well, you can't see me if I sit there. I can't see you as well. Can you hear me all right? Yeah, good. So, I'll just quickly introduce myself. I'm Jed Boardman. I'm a consultant psychiatrist in London, and my main job, my main clinical jobs, working with people with long-term mental health problems, predominantly people with psychoses, schizophrenia, bipolar disorders. And all my work is in a community team based in South East London. And it's a relatively deprived part of South East London with a large, particularly African and Afro-Caribbean population. So you can imagine the sort of area I might be in if you've ever visited London. What I thought it's a very difficult giving these talks because you never quite know what the agenda is for everybody else in the room. So, but one thing I think you do find is that many of these issues about poverty and social exclusion are sort of universal in many ways. And the same issues come up in many countries. But of course, what comes up in your country you will know far more about than I do. But I do know about poverty, social inclusion, and mental health in England or in the UK. Now, the other day, I had to give a talk to the Ministry of Health people. Well, some are here. And what I said to them, I thought the biggest real change, the two main things that I think have helped the development of mental health services and support for people with mental health problems in the UK, particularly those with long-term severe problems, have been two things since 1945, i.e. the second half of the 20th century. One was the closure of the large institutions, our large asylums, which had grown enormously in the 19th century when they were first created, and by 1955 they were at their peak of occupancy, i.e. they had the most people they'd ever had in them. After that, the number in those declined, and we moved over to providing mental health care mainly with multidisciplinary teams in the community. So nowadays, in a sense, we've moved from a lot of beds to very few, but the very few we have are mainly for adults, acute beds in general hospitals or in smaller psychiatric hospitals. And this sort of setting, you can see there, a sort of mental health centre or a specific building houses many of our teams up and down the country. In all areas will have a generic mental health team. There are many others, but they're the sort of central hub of them, and that's the sort of place I work in. Sadly, don't work in that place anymore. I did in the past, but not now. And the other thing I think has helped actually create and help us support people with mental health problems outside large was the development of a decent welfare state. And all I'm showing there is, it was William Beveridge's report, and by 1947 the then Labour government started to create what he thought was an adequate welfare state. And what he wanted to cut down was want of all the five giants: want, ignorance, disease, squalor, and idleness. Want is about poverty, ignorance is about education, disease is about health, squalor is about housing, and idleness is about employment. So those are sort of key parts of it, in a sense, of that welfare state. And of course, what I work in is essentially that part of the welfare state, the National Health Services. And most of nearly all our services that we provide locally to people are provided through the National Health Service. So it's free at the time of use. All taxpayers' money that pay for it, of course. So that's, I think, what has supported, actually, that move from hospital to community. Now, if we want to think about this, and I think I said yesterday, it's a sort of complex relationship between poverty and mental health, or social exclusion and mental health. You can think, of course, that poverty causes mental health, which is partly true. You can think that mental health causes poverty, which is also partly true. But I think the best way to often look at it is in these cycles, the idea of cycles of deprivation, i.e., the two are interacting factors, really. But of course, what you might want to consider actually is that many people with mental health problems do actually suffer from poverty, or they're in some way deprived or socially excluded, and their mental health can make that situation all the worse. Now I couldn't think how to put all this together for you, but at least I think what we've done in the UK about this has been at a sort of several levels, because these things don't exist, these changes don't occur at any one level. And I sort of think we can identify things at the broad policy level, the broad service level, the professional level, or the givers of services, if you like, professionals and non-professionals, and also at the level of service users and families. So I think what have we done recently over the years? Well, one of the problems I have at the moment is how to talk, if I talk to the government in any way, to government departments, how do we talk about poverty? Because they don't kind of like this word. Politicians are a bit dodgy about it in the UK. It was easy when we had a Labour government because they pushed social exclusion, but the current government talks about this nonsense of the big society. And they kind of slipped away from the idea of deprivation and social exclusion. So we've got to always be careful with governments, how we address matters of poverty and social exclusion. And sometimes you've just got to take what is if you like, the current government opportunities to actually interact with them. That's at least what I found out over the years. What we have had, I think, though, that's been important in recent years is a thing called the Disability Discrimination Act, which is now in the in the Equalities Act. They put all our discrimination acts together. But what that did, it was mainly to do with made it illegal, if you like, non-legal, to discriminate against people with disabilities. And included in that was people with mental health problems. So there's a kind of aspect of law that does actually help people generally with disabilities. When that first came out, my criticism was it wasn't an equal playing field between people with physical disabilities and people with mental health disabilities. But they have made changes to try and equalise that, if you like, because I think governments always find it hard to actually accept the sort of disabilities associated with mental health problems. It's much easier to see the physical disability because they're more visible. We've also got Human Rights Act, which our current government doesn't like, but I think is very useful. We've had the disability rights. We also created in the 90s, and it lasted until 5 years ago, was a social exclusion unit. And that's where the idea of social exclusion became very explicit in policy. And that unit was very helpful. It was part of the Prime Minister's office and then Deputy Prime Ministers, and did actually report quite well on social exclusion and mental health, but also on social exclusion in children, and the notion of sort of early intervention in terms of trying to prevent mental health problems was key to that. We've also had a lot of sort of aspects of health and social care, but we have had reports and initiatives on health inequalities, which I talked about yesterday, which of course mental health inequalities are part of that. That's the fact that, in most ill health problems, most diseases, there is a sort of gradient between high numbers in those with very little to less of it in people who've got a lot more money and status. And we've also had a new Mental Health Act, and I think the idea of recovery has been very integral to mental health policy, and I think that's been very helpful in the way governments have started to think about mental health and people's rights and freedoms. We've also had concentration often on children and families in many of the policies about children and education. So what about the broad service level? Well, I've said before, in mental health, the biggest issue I think that's helped think about the condition of people within communities has been our development of mental health teams. But of course they can't operate as well without all the surrounding social paraphernalia like decent housing, like decent welfare benefits and so on. We've also had a big move in our physical health policies because of the notion of chronic long-term disorders. And of course, long-term disorders are part of what mental health disorders often are because of the relapsing conditions, longer-term disabilities, fluctuating conditions. In public health, we've actually brought public mental health into the fore, which has been very helpful. I don't think it's gone very far yet, but it is there, it is talked about. And we've also had a lot of talk for many years about health inequality and what to do about it. Social care, there's a big move towards personalisation. That's thinking about the individual rather than having a sort of, you know, one-size-fits-all type of approach to personal care. We've also had, I think, a large development since really the 1940s on development of social housing. And remember, it's the local authority's responsibility to house people who actually are made homeless in their local area, which is very helpful when you're trying to sort of find somewhere with a mental health problem, somewhere to live. Because it does mean that it's their responsibility and we can't find social housing. Employment, I've talked about the sort of ideas of disability. We've also had some mental health welfare reform recently, which I think has been damaging in some ways. It just shows that it can be helpful and damaging as well. We've got adult education, which partly because of the Disability Act actually has to sort of make reasonable adjustments for people who have disabilities, including those with mental health problems. We've had an emphasis on early intervention in children's services. We have an independent sector. I think it's a new. There's some NGOs here. It's mainly charitable organisations, not-for-profit organisations that do provide a lot of our services, including things like welfare advice and debt counselling, which is relevant. We've had the national stigma campaign, which is called Time for Change, which I think has been largely helpful. And we've also had this initiative. That's the last bit anybody spent any money on trying to improve access to psychological therapy.
Don't the rehabilitation explicitly here?
Well, I think when you talk about rehabilitation, that's rehabilitation in a way. Most of those community mental health teams deal with the same things as when you talk about rehabilitation. We do have specialist rehabilitation teams, and they deal with perhaps the most challenging patients. But actually, that's pretty much what you need. Okay, what about specific services? Well, there are some things that will help people in terms of their employment and housing and so on. And I think this is important just to realise that a lot of these specific intervention type things are evidence-based to some degree. You know, there is usually historically we've always had people with severe mental health problems into some form of employment, but it's usually been sheltered. The move is now to have them try and help them into open employment in the open market. And there are some very good schemes called IPS, which you may know about, individual placement and support, that can support people. And I think there's about 17 randomised controlled trials, all of which show that's better than the old-fashioned way of doing it. We've also had a lot of policies about workplace support, because of course in a way, a lot of people with common mental health problems, anxiety and depression, actually are working. And of course when they go off sick, that causes big problems trying to get them back to work. And so we've had a lot of focus on trying to either prevent common mental disorders in people with employment, or to get them back to work in a timely manner. We've also spent some time trying to look at the health and mental health of our own workforces. Housing, we've always had for a long time sort of some form of supported housing for people with mental health problems. However, most people with schizophrenia, with severe mental health problems, actually live in independent housing. But there are housing support schemes, particularly for them, particularly about their tenancy and keeping those tenancies. There's also a scheme.
Excuse me, so do you mean kind of rent subsidies? Are you talking about the housing itself or the services that support housing?
Well, both actually, in a way. I was actually talking about some supported housing. It varies from high support, where you have staff living on site, to low support, where they maybe visit daily. But we also have people who are floating support workers, who go into people who are living usually in rented accommodation, social housing, and support them in those houses. And some of them will be just for the support for the housing matters themselves, like paying their rent properly. Others will be support workers from our teams. But you also get, through our welfare benefits system, you also get, if you're on benefits, you get housing benefits paid. So the bulk of your housing costs, i.e. your rental costs, are paid by the state. And I was actually, that was my next point about that, because welfare benefits have been an important way of keeping people, particularly who find work difficult and can't get into it, keeping them, if you like, their heads above water. And one of the important benefits is housing benefit, but you also get disability benefit, and you also get out of work benefits.
And you see how much it is?
Do you know, on the top of my head, I can't remember. But
how is it like relative to the minimum wage? If you have a minimum wage?
Well, we do have a minimum wage, and it will. Well, if you manage to get the right benefits. Now, if I was talking to one of my people who come to see us in our team, I'd want to know if they got out of work benefits or some equivalent, and they got a thing called disability living allowance. That's a benefit to pay. It's available to all disabled people, and that pays the extra costs of disability. That's, in a sense, their income coming in. But the other cost, because the main cost of living for most people is their housing rent. And if they're getting all those, they will be able to live quite comfortably above, I think, what you would expect to live above the minimum wage. You can get other benefits if you're in a family, because, of course, there are sort of carer benefits as well that you can apply for. But most people, probably the majority of people, or at least the largest percentage of people with a diagnosis of schizophrenia, will probably be living on their own in reality. Not all. Some will live with their families. But also, there are things like welfare advice workers, because this whole business of obtaining welfare payments is complex, and people are always getting into messes about it, either because the departments who pay that money make mistakes, or people aren't applying for them. And you do find that if you give them welfare advice, that can often make sure that they can keep their welfare benefits. We also have debt counselling, because of course, you know, it's not unreasonable for these people to get into debt. And for some, you can apply for local authority grants for some of their housing needs. And remember, there's also legal protection for those people without capacity to manage their affairs, which can be helpful as well. And you often transfer the management of their affairs to somebody in the local authority. We've also got adult education, which is helpful because we often do a lot of signposting, like sort of suggesting that people go to adult education classes. But recently we've started to develop these recovery education colleges, we're going to talk about later, within our sort of community teams and hospital systems. We've also had a whole set of, I think, a whole look at early intervention. I shan't go all through those, but there are a number of evidence-based approaches to early intervention. All those were taken from a report that we produced on the cost benefits of early intervention. And also, this is one of the things that we have done in the past, is the idea of community development projects, which I think are familiar to everybody around the place. But actually, I think the one thing that I think we've failed to do well in psychiatry, and we certainly have nothing to do with this in our teams, is this type of community development project, which I think is a sort of an area that I suspect you'll be interested in, and that we've not taken enough trouble, I think, to do and look at and integrate our systems. At a professional level, and I think this is probably important, we've had most professional organisations, most professional organisations have taken a big interest in, if you like, the social aspects of mental health. And that's because I think partly medically, we've always had a sort of tradition of social medicine in the UK. Social psychiatry is very, it takes from that. But also, recently, many of the medical Royal Colleges and many of the, the nursing, the psychologists and others have campaigned for is this idea of parity of esteem. That means that in a way that we've always seen a sort of unequal distribution of resources to people with physical problems as opposed to mental health problems. And what we've campaigned for is that level of resources should be similar for each of those disorders. And we've managed to get some of that put into the more recent acts and reports of Parliament on what the responsibilities of the Minister of State is. We've also accepted, things like recovery, and we've had joint initiatives between many of the professional groups on this, and I've led on the college about this, and we've produced professional sort of statements about the importance. Increasingly, we've looked at service user involvement. I know, for example, at the Royal College of Psychiatry, we have our own service user and carer groups there, which then come on to many of our other committees at the college. And of course, training has been important because many of us have tried to look at improving training to help professionals realise the importance of social problems. Stigma has been another thing that many people have campaigned for. And latterly, I put the term compassion because we had a bit of a disaster in one of our areas of our hospitals in the country, which really, because I think of poor management and a lack of compassion, people were badly treated, if you like, and it was a scandal. And I think we've always realised that you can't treat people properly as a professional without some sense of kindness and compassion. And that relates to the idea of having a value base to what you do. And I think that's become a big part of it, not just in professionals, but also in policy. And finally, we've got the sort of whole service user level stuff. Now, in a way, we've always had a strong disability movement in the UK, but it was predominantly representing people with physical disabilities. And what made that stronger, actually, funnily enough, was the realisation that many people with physical disabilities were living in poverty. And you remember I mentioned about the disability payments people get. Well, that disability payment came out of the fact that people with disabilities were living in poverty. And they've been very strong. And I think what I think everybody should learn from that movement is, firstly, that collaboration is important. But also what they were asking for constantly was the idea of access and independence. And I think you can apply exactly that to what many people with mental health problems need. Mental health user movement, it's there. It's a little more divided and not as well organised, I think, as the physical disability movement. But it's been strengthening over the years. And it does have a voice, partly through organisations like Mind and Rethink in many policy areas. We also have a lot of people who work specifically as advocates for people with mental health problems, and everybody has access to that. Increasingly, we've looked towards peer support and good training for peer support workers to work in mental health services. And also, we've paid a great deal more attention, particularly since about 2000, to the role of carers and their rights and voice as well. So we've had things, I think, at many levels. And I just wanted to bring that up, really, to people, because I think, it's not just about having government making sets of decisions, if you like, and policies. It's also about what people do from the ground as well. And you can't run, in a sense, our mental health services as a clinician without that surrounding, if you like, infrastructure to help people live a decent life in the community. I can't do it without housing help, without employment. without those things. And I think whatever we do, we need to base our things on both a sense of collaboration with people and co-production, but also in a sense of principles, which we must have a say in. And I think that's about it. Thank you. I'm sorry, I probably went over my 20 minutes.
Thank you, Jen. Next is Dr. Rosen, Director of the Smokeless Center for Health Policy in JDC.
Sylvia, we can't hear you here.
You have Bruce now, which is much more important.
התכוונתי להציג בעברית וגם השקפים בעברית, אבל עכשיו סופיה ביקשה שאני אדבר באנגלית, אז אני יודע לבקשה הזאת. אז יהיה לכם את העברית מהשקפים והאנגלית מהדיבורים. So what I was asked to do was to try to pull together data from several different sources about what do we know today in Israel about the links between poverty and mental health. And as you'll see, the different data sources really complement one another. They look at different aspects or dimensions of mental health and different aspects of poverty, different time periods. Of course, there's a lot that we don't know, but it was a little reassuring to know that we actually do have a fair amount of information, and that's what I'll try to cover. So, as I look at each source, I'll talk about what year it's from, whether it's talking about the individuals or the locality level, what aspect of mental health they looked at in that particular study, and what aspects of economic well-being were looked at. So certainly one of the most significant data sources that we have is from a joint study done by Brookdale and with the National Insurance Institute, from 2009. It's called the Laron study. And it looked specifically at people with mental health disabilities in the working age population. It looked at people with disabilities in general, but I'm going to focus on people with mental health related disabilities. It has individual level data. In defining the group to look at, it looked both at people who have disability allowance, mental health related disability allowance, but goes beyond that. Also included people who in the general health questionnaire talked about having mental distress and had a functional impairment related to mental health for at least a half a year. So this is people with quite serious issues. This is not, and it also looked at a range of economic indicators, which I'll show you the findings about them in a second. So first about employment. What's the structure of the chart? So we'll have one column, which is about the general population, which is not from this particular survey. It's taken from other, usually Central Bureau of Statistics, various surveys. And then from this survey, we have about people who have a mental health-related disability, but also about people who have both a physical and a mental disability. So about employment, in the general population, for this age group, 72% were employed. And in these groups, of course, quite a bit fewer are employed. And with these groups, we also have information about their motivation to work. And as you see, quite a large, I think we all know this in the room, quite a large proportion of the people who aren't working would want to work. The next topic is, do people have a matriculation certificate, completion of full high school? And of course, there are more people who do not have such a matriculation certificate. What?
Can you show the previous slide?
The next slide.
The
previous slide where I define the study?
No, never mind.
Okay, you know what, I'll give you my slides here. Okay, so as you'll see, dimension after dimension, obviously people with mental health disabilities are a worse situation. I don't think that's a surprise to anyone. The point here is it's also good to know the numbers, and it's also good to know that there are sources. So if we afterwards we want to go back at some future time, look at it, we have them. If we want to compare over time, we know to know what baseline data we have. People whose personal income less than 4,000 shekels a month among people who are individuals as opposed to couples. Obviously, much higher rates among the people with mental disabilities. People who describe their income, their economic situation as really not good, almost double in the general population. More than double if we're looking at people who can't finish the month, who can't cover their basic costs. And also much lower rates of people who had to forego really basic things like dental care or prescription medication. So that's from this source, and this is data from 2009-2010, which is not so long ago, but still 5 years have passed. I'm pleased to be able to report that currently there's a study underway at Brookdale Institute by the Disabilities Division, also with the assistance of the National Insurance Institute, we have a big survey among a similar population, people with serious mental, well, people who are receiving the disability benefits of mental health. The focus of the study is about the services, the mental health services they're receiving, and the connection between different mental health services, between mental health services and physical health services. But the survey also includes quite a few questions about their economic status. So we're going to have pretty soon fresh data about these issues of the links between mental health and economics. Yes, please.
I'm not sure I understand well, and I want to just make sure. People with the physical disability are working less and have less motivation to go to work.
There's another column that I didn't show. I thought there was enough numbers here, which is people who have a physical disability but don't have a mental disability. This is people who have both. So you have a double whammy.
So we don't have this.
So we have it in the book, and we can give you a copy of the booklet later. Okay, I'm going to go on to the next data source, if that's okay. But if you wanted further information about that new study that people talked to at the break are Daphne and Elise. I think we're very excited about this new survey. It really creates some really important information. The next survey is, there was, in 2003, there was this big, I'm sure you're all familiar with the World Health Survey, and Daphne was in charge of the Israeli component of it. Again, the individual from age 21 plus, used a diagnostic questionnaire, so we really know what the problems, what mental health problems that people had, and they have information on income per person. So these are the odds ratios from a logistic regression, trying to figure out the predictors, basically, of various disabilities. And the other, also in the equation, we have things like age, and I think nationality, and gender, of course. So if we take all hafraot, all English is missing, all disorders. So there is an effect. It's this is the column. This is the odds ratio of people with low income. So it goes up to 1.24, but the effect is not statistically significant. Similarly, if we take this next row deals with affect disorders. Is that the right motion? And here it's a smaller odds ratio, also not significant, but when it comes to anxiety disorders, the odds ratio goes up to 2.2. So much higher rates of anxiety disorders among people with low income.
Bruce,
Yes.
if I recall correctly, I think it didn't include schizophrenia, but Daphne could tell us about that.
Schizophrenia was in it, but it wasn't defined as schizophrenia.
So they're in this total, but of course they're small, in terms of number of people involved, it's a small number.
Was not defined specifically.
It wasn't defined specifically.
Right, so obviously these are the people with very serious illnesses, but in terms of the numbers, the big numbers of people, as we all know, are the people with the anxiety and affect disorder. So this is significant. And then the question about the severity of the disorder. So also odds ratio above 2 and a strong link with income statistically significant. Is that clear? Okay, the third source is from a recent survey that we did at Brookdale Institute. We looked at the general population